Forced removal of Foley catheter is a common occurrence amongst agitated or delirious patients. Removal of a Foley by such means is often traumatic to the urethra in males and often leads to urethral injury. However, the presentation of a bladder hematoma is a much more serious consequence of unintentional Foley catheter removal and needs immediate surveillance and surgical intervention. Clinicians must maintain a high level of suspicion for catheter-related bladder injuries, especially in a patient with altered mental status, prolonged hematuria, and rapidly dropping hemoglobin levels. In this case, a 30-year-old patient was with a past medical history of bipolar disorder and polysubstance drug abuse presented to a tertiary hospital in Miami with altered mental status due to polysubstance overdose. Workup revealed acute renal failure, rhabdomyolysis, hepatic failure, lactic acidosis, and severe electrolyte imbalances. Upon arrival to the emergency department, he was unresponsive, apneic, it showed agonal breathing, and had fixed and unequal pupils. The patient was quickly intubated and carefully monitored. However, during an incidence of agitation overnight, the patient forcefully removed his Foley catheter with the balloon still inflated, and he began experiencing prolonged hematuria. On day 20, patient received a CT of the abdomen and pelvis with contrast, which showed a 12-centimeter hyperdense lesion in the urinary bladder representing a hematoma. This could be seen in Figure 1. An ultrasound of the urinary bladder on the same day showed a 12.6 by 9.2 by 8.5 centimeter heterogeneous structure within the urinary bladder that also represented an involving hematoma, which can be seen in Figure 2. Urology conducted a cystoscopy with clot evaluation and fulguration of bleeders on day 21. The bulbar artery was the source of the lesion and the main culprit leading to the prolonged bleeding in this patient, which had occurred over the course of almost 3 weeks. Post-op ultrasound of the pelvis showed an underdistended urinary bladder with a Foley catheter in place, and the previously seen large hematoma was no longer visualized, which can be seen in Figure 3. There was no longer any more hematuria or pain in the suprapubic area post-procedure, and the patient's hemoglobin levels started trending upward with packed red blood cell transfusions and eventually iron sucrose treatments. As you can see, the labs on admission showed severe and systemic and widespread dysfunction and electrolyte abnormalities. What's more important is noting the pertinent hemoglobin levels. On day 1 of admission, the patient's hemoglobin was 13.4. His hemoglobin prior to the ultrasound of the bladder, which was conducted on day 20, was 7.0. His hemoglobin 1 day after the surgical procedure, which notes day 22, is 5.1. His hemoglobin on day 29, which is 5 days after iron sucrose treatments, his hemoglobin was 10.2. And finally, his hemoglobin 1 month after the initial trauma, which marks day 31, is 10.5. While there's a wide variety of causes that can lead to frank hematuria in male patients, clinicians must keep a high level of suspicion for unintentional Foley catheter injury. Lab work such as complete blood count, basic metabolic panels, and urinalysis should be obtained as part of the workup. In hemodynamically stable patients, CT of the abdomen and pelvis or ultrasound of the bladder are both able to diagnose bladder hematomas. However, in instances of hemodynamic instability, cystoscopy is indicated because the source of bleeding must be tended to immediately. With this patient, he was hemodynamically unstable for an extended period of time. After surgical intervention, packed red blood cell transfusions, if appropriate, can be used, and iron sucrose treatments can help stabilize patients' hemoglobin levels. Amid many other complications, bladder injury and trauma due to unintentional Foley catheter removal may often be overlooked. There should be a high level of clinical suspicion if a patient is actively bleeding for an extensive period of time with rapidly lowering hemoglobin levels requiring multiple packed red blood cell transfusions. This should alert clinicians for a prompt urological intervention, especially in a patient with altered mental status, prolonged hematuria, and rapidly dropping hemoglobin levels. Thank you very much for listening to my presentation.